LTHT. I am Alison Raycraft, lead nurse for older people, and this is my colleague, Sean Ninan, clinical lead for dementia.
Alison.
Sean, can you tell us what the new requirements are?
Yes, absolutely. So we've now introduced that it's mandatory for people over 65 years old to have an assessment for delirium called the 4AT. And if they either have delirium or they're high risk for delirium, that will be evidenced by a 4AT score of more than 0. They should have some interventions put in place to prevent or manage it. So basically, if you're over 65, you have to have a 4AT done. And if your 4AT is in any way abnormal, you have some interventions by means of a delirium care plan.
And why is the Trust introducing these changes?
Well, first and foremost, it's to improve care. Delirium is a very common problem in hospital. It's preventable. It causes a lot of harm and distress to patients themselves. It causes difficulties for staff in terms of looking after patients and can lead to all sorts of harms if left unchecked. It's also part of national guidance now. So the GIRFT Get It Right First Time report for geriatric medicine suggested that we should do a triple assessment for older people when they're acutely admitted to hospital. So that's in use to the clinical frailty scale, which people will also have seen starting to be used more regularly, and this other test that we're going to be talking about today, the 4AT, which is a cognitive screen.
Let me go one step back. What is delirium?
What is delirium? Good question. So delirium is basically a condition characterized by acute confusion. Often people have an acute memory problem, but they may also have problems with hallucinations or paranoia or delusions. They often struggle with concentration. So as well as an acute confusion problem, there's an acute attention problem. And people may take to bed or be agitated. It's typically caused by an acute illness of some sort, and often there's multiple things contributing to delirium. And it's not a part of a pre-existing condition. So it's not something that happens as a fluctuation in someone's dementia, for example. It's something new that's occurred. So that's broadly what delirium is, an acute confusional state characterized by inattention as well, and caused by something specific that can be treated.
Well, I guess it makes sense that as you as a geriatrician care about delirium, it's what you specialise in. Is this an issue for other departments?
Yeah, absolutely. So, like you said, on wards like mine, the geriatric medicine wards, delirium is very common, but it's actually very common across the whole hospital. So, right now, around 20 to 30% of patients at LTHT will have delirium, and that will be even higher on some places, like, for example, an orthopedic ward, a hip fracture ward might have a prevalence of closer to 40 or 50%. ICU is a very high area place for delirium. But actually, all medical and surgical specialties where there are older people are going to have delirium on their wards. The problem is that it's often missed. So around 2/3 of cases of delirium aren't picked up at all. Doctors and nurses don't know that they're missing it.
So we're missing delirium a lot. Does it matter if we miss it?
Yeah, absolutely. So there's obviously the possibility of a patient suffering and us not being totally aware of that, families being distressed about that as well. But real measurable harm occurs to patients who've got delirium. So people who have delirium are at higher risk of falls, they're at higher risk of deconditioning, they tend to stay in hospital much longer, they are more likely to go into nursing homes, and they're at higher risk of dying. So some real harm is translated to patients who've got delirium. I think the distress element shouldn't be under-recognised. So if patients have delirium, it's often more detected by family members who know them really well. So they're the ones coming visiting, after hours, after the doctors have done their rounds, and wondering why their mother or their relative is like this in this way, and need some answers for that. And I think the thing is as well, just important in terms of everyone's care. So if you're a specialist looking after one condition, then it's great to do a successful operation or fix a specific condition. But if you ignore everything else that's going on with the patient, then the patient isn't going to have a good outcome. And the way I sometimes explain that is, if you're a mechanic and you've done a really good job at repairing an engine, you wouldn't just ignore the burst tire that was going on as well. So really important that people recognize this problem that's occurring to their patients and do something about it.
How do you diagnose delirium?
So delirium is diagnosed by something called the DSM-5 criteria. So that's where there's an acute confusional state. There's a problem with attention, and attention can be measured in a couple of ways. It can be measured in a test called the months of the year backwards, which is what we're going to explain shortly. But it's also something you can see. So attention is your ability to sustain concentration. So as you and I are talking now over Teams, it's fairly easy to concentrate on what's going on, unless there's lots of other things going on around us. So if you're in a busy office and people are talking, we've got to filter that out. If somebody comes into the room and says, Sean, can you just help me with this? I've got to switch my attention to that. And attention is basically our ability to concentrate on one thing at a time, shift focus to what we need to focus on when a new stimuli is there. And people with delirium really struggle with that. So an acute confusional problem, a problem with attention, it's not caused by a condition that the patient already has. So like I mentioned, for example, it's not caused as a result of somebody's pre-existing dementia, for example. It's got a specific cause, and typically there are multiple contributing causes to it. So that's how you diagnose it, and that's how kind of doctors and experts will diagnose it. But we're suggesting that people screen for delirium using a simpler tool called the 4AT.
So how do we treat delirium?
So I guess if somebody's got delirium, then the things we have to do is treat the underlying cause. And sometimes that'll be really obvious because that might be what the patients come into hospital with whilst they've developed a delirium. Otherwise, we might need to look for contributing causes. And typically, there are multiple contributing causes. So people often think about infection as a cause of delirium, but things like pain, constipation, urinary retention, medication side effects, problems with hearing or eyesight can all contribute to delirium. So it's really important that we look at multiple things at the same time if we're going to treat delirium.
Can you stop people getting delirium?
Yeah, absolutely. So the prevention of delirium is very luckily the same way that you treat it. And if we were able to identify patients at high risk of delirium and put in place these measures for prevention before they got delirium, we'd prevent around 30 to 40% of cases of delirium, which is quite a significant amount, and a potential to prevent quite a lot of harm associated with it. I'm just going to share a screen in a second if I can do that. Wow. So there's things that I mentioned a second ago in terms of potential contributors to delirium can be remembered using this mnemonic pinch me. So P stands for pain, and making sure people have got analgesia, if they've got a condition that might cause them pain, is really important. Treating infection when it's there. Nutrition's a really important part of managing delirium. So if you go without food, unsurprisingly, your brain suffers. So making sure people are eating and drinking is a really important part of managing or preventing delirium. And that's where the hydration is there as well. People who've ever worked on a geriatric medicine ward or an elderly medicine ward will notice that we're obsessed with making sure people's bowels are opening regularly, and that's because that's an important contributor to delirium. Thinking about a catheter, so that's a bit of a complicated one because unnecessary catheters can cause delirium. It can be quite irritating to have a catheter in. However, older people are also at higher risk of urinary retention, and that can sometimes go missed. And if people are struggling to pass urine, then that can be quite distressing and cause delirium in itself. So sometimes people with painful urinary retention need a catheter put in to treat delirium. Thinking about medications and then thinking about the environment. So we mentioned the need for kind of hearing aids and glasses, but also in terms of reorientating people, just telling them that they're in hospital, asking relatives to get involved, and providing a quiet environment, making sure people are sleeping well, really important ways of preventing delirium. So this simple mnemonic is a way of thinking about the preventative measures for delirium, and it's part of a little card we produced, isn't it, in terms of something that a resource that ward staff could have to take away with them. So this has got the cognitive test for delirium, the 4AT on it on one side, and also the contributors, the pinch me mnemonic on it as well.
That sounds like a really good thing. If you stop delirium, can you prevent the other harms that come with it?
Yeah, absolutely. So I think the best evidence for that comes from falls. So we know from high quality randomized controlled trials that preventative strategies for delirium reduce falls rates quite significantly. We don't have the data for other harms, but you would imagine that it would do. So if you're preventing a delirium, you should reduce length of stay. You should reduce deconditioning, which is very highly linked with delirium. And other harms that are associated with it. But it'd be true to say that the best evidence that we have for that is in terms of reducing falls risk.
Going back to the 4AT, how would you do a 4AT?
How would you do a 4AT? Well, let me show you. I'm just going to bring up a test patient. Share my screen again. Okay, so the 4AT, you should be able to see my screen now, hopefully. Of this Mickey Mouse test patient. So the 4AT is a clinical document in PPM. So if you add clinical document, and you'll see that 4AT is one of the ones that I've starred, but it's also near the top, and you can fill it out on PPM itself. It's fairly self-explanatory, so it doesn't require any specific training, although it is kind of useful to hear what we're about to discuss right now. If you fill it out on PPM, what's quite useful is that each of the areas here have an explanation box that explains things in a bit more detail. So the 4AT stands for the 4 A's. And the first A is a test of alertness. And that's simply seeing how alert somebody is. So people are allowed to be asleep. And if they wake up and then they're normal, then you can score them as mild sleepiness for less than 10 seconds. If they're clearly normal, fully alert, but not agitated throughout assessment, you'd score them as normal. And if they're clearly abnormal, so these are people who are kind of clearly obviously agitated or distressed or clearly obviously drowsy, you click on clearly abnormal and you'd score for that. You'd score 4 points if that was the case. And like I say, this information box explains that in a little bit more detail about how to do that. So that's the first day, alertness. The next day is AMT4, and that's just a very quick test of 4 questions. So we ask people how old they are, we ask their date of birth, we ask them to say where they are, and you can see in brackets underneath, they have to say the name of the hospital or building, and we ask what year it is. So age, date of birth, place, and year. And you score 0 if you get everything right. If you get one thing wrong, you'd score 1 point, and if you got 2 or more things wrong, you'd score 2 points. But the good thing about doing in PPM is that the scoring you don't need to think about. It will score everything automatically for you. Then the next A is attention. So that's what I was talking about before in your kind of ability to sustain concentration. And the way you test that at the bedside is by doing this test the months of the year backwards. So this is where you say to somebody, can you do the months of the year backwards starting from December? You're allowed to just give them one prompt if they struggle or they say that sounds a bit hard. You say, come on then, start with the first month before December. What's the month before December? And then you're not allowed to give them any more help. If they get to June, they pass. So if they get to June, you can pause at that point, but they must get 7 months correct to pass that test. And again, there's options. So achieve 7 months or more correctly would be the only way to score 0. If they started but didn't get to June, or they just said, no, I'm not trying that at all, but were able to at least answer the question to some degree, they'd score 1 point. But if they were untestable, so they couldn't start because they were drowsy or inattentive or unwell, then they'd score 2 points. So it's clearly not a good sign to not be able to engage with the question at all. And then the last A is an acute change or fluctuating cause. And that's simply observing whether the person is more confused than they usually are. And again, if you hover over the information box, it explains that in a bit more detail. That should have arisen over the last 2 weeks and continued in the last 24 hours. So that's a test of whether there's been acute change. So a test of alertness, an AMT4, a test of attention, and describing whether there's been acute change. This is the 4AT, and the easiest way to do it is to do it within PPM itself, because all the explanation and guidance is there, and the scoring system is also there for you.
Okay. How can you score for an acute change if there isn't someone who knows the patient?
Yeah, so that's something that people often struggle with, and I mean, when I do the 4AT very regularly, I've got exactly the same issue. So I think there's a couple of things to be aware of here. The first is, if for example you're in A&E or an assessment area and somebody's come into hospital clearly more confused than they normally are, and maybe that's even the reason why they've come to hospital, then you should score them as yes for acute confusion, even if you're not able to confirm that exact moment. So I regularly see 4AT scored as, being unable to assess whether there's acute confusion when the patients come into hospital because of their acute confusion. I think we're allowed to assume that that's the case if that's why they come into hospital. If you don't have that, then clearly you need to ask somebody who knows the person well, and that's typically a relative or a caregiver. It may, of course, be yourself. So, if you've been looking after somebody for a few days and they're more confused than they were yesterday, you're like, oh, that wasn't what Mr. Smith looked like yesterday, you'd say there's been acute change and score it at that point. So that's how you do it. If you are completely stuck with that and you really don't know if somebody's more confused than they normally are, and that's often the case for me on a Monday morning, for example, when I get a bunch of new patients and they've been in hospital for a few days, they've clearly got some cognitive problems. I'm not quite clear if they're worse than they were last week or not. I would have to click on unable to assess. But if you've got the history that someone's coming with acute change, then please do click yes to that question.
I think some nurses might be quite worried about getting this wrong.
Yeah, no, that's a common issue we've come across, isn't it? And what I'd say is, like, genuinely don't worry. No one's going to get into trouble for getting the 4AT slightly wrong. And the issues that people have with it are no different to the issues that I have. The other thing I'd say is, in terms of the interventions for a 4AT, that they're the same whether your 4AT is 1, 2, 3, 4, or 12. So if you score any abnormality on a 4AT, you're at higher risk of delirium than you should be, and you should have some preventive measures put in place. So whether you get one aspect slightly unsure, you're slightly unsure there's an acute change or not, often those people will have scored positive for something else, like getting their place wrong or not being able to do months year backwards. And if that's the case, you still put in the same interventions, no matter whether there's an acute change or not. And it might be up to somebody else to later decide whether this is a case of delirium or not, but you'll do a lot of good for that patient if you identify them as being at risk and put in place some preventative measures.
How long does it take to do a 4AT?
It's very quick. We could demonstrate now if you're up for it.
Yeah.
So like we mentioned, the things were whether there's been an acute change, an observation of somebody's level of alertness, and then just a few questions. So I'm going to ask you those questions. Would you mind sharing with us how old you are?
55.
What's your date of birth?
2004, 1968.
What year is it now?
2023.
And where are you?
St James's Hospital.
I've got one last question for you. Could you tell us the months of the year backwards, starting from December?
December, November, October, September, August, July, June.
Stop you there. So, in somebody who's cognitively normal, such as yourself, you can see that asking those questions itself takes about 15 seconds, I guess, or maybe 20 seconds. And then the only other things I need to do, so those were two of the A's, the AMT4 and the test of attention, the months of the year backwards. The other two A's are a simple, observation of how alert someone is, and then whether there's been acute change or not. So in itself, the test is not a difficult test to do. It's not a time-consuming test to do. There are some people who will try to answer the questions more slowly and take a bit of time doing it. That sometimes takes a minute or so. It's not a long question, and the guidance says it should take less than 2 minutes to complete, which I find in practice is typically much less than that.
And then just what does that mean once you've asked those questions?
Yeah, so that's a good point, isn't it? So there's no point in doing an assessment and just writing it down somewhere and nothing changing for the patient. So I think there's a couple of things here. One is knowing someone's cognitive state. So rather than kind of just saying that person's alert, they don't seem that confused, seems a bit confused, pleasantly confused. We've now got a number, and once you start to get used to that, you'll have a feel of what a 4AT of 0 or 1 or 2 might look like in an individual patient. But also, we are going to put some interventions in place regarding this. So if your 4AT is more than 0, you should have some measures put in place to prevent delirium using the delirium care plan. If your 4AT is more than 4, then you're fairly likely to have delirium, and you should have those same measures put in place, and there should be a bit of extra medical work put in around that to try and diagnose delirium and diagnose the other potential contributing factors.
So I think you've answered around what you should do with the 4AT score, but what does that mean for nurses?
So I guess it's about trying to do the things that we all know that we should do. So what we're suggesting is that we put in a delirium care plan, and I will try and share that at this moment. That's a second. Hopefully you can see that at the moment. You see that?
Yep.
Yeah. So it's a bit about providing kind of high quality, reliable nursing care. So if your 4AT is more than 0, we're going to be saying this person's at risk of delirium. We need to make sure that they're not in pain. We need to make sure that they're eating and drinking properly. We need to make sure that they're not in urinary retention. We need to make sure they're opening their bowels regularly. We need to try and do something around the environment to try and make it as least deliriogenic as possible, which I appreciate is hard to do. We need to make sure people are sleeping well. We need to make sure that the patient and family know that they're at risk of delirium, and to be able to explain that to them and use the delirium leaflet when that's appropriate, and just make sure that the patient's not in distress. So instead, when we're seeing somebody with delirium who's agitated, just thinking about what that unmet need is for the patient. Are they thirsty? Are they hungry? Are they in pain? What can we do for them? So I guess it's about providing reliable care. So these are the things that we know can prevent delirium. These are the things we know help to manage delirium. And I know we do this to some extent already, but we need to be able to do this reliably and consistently for the best outcome for our patients.
Isn't that what nurses already do?
Yeah, to some extent, yes, absolutely. And I know a lot of good care already occurs. But like I said, I guess this is about making sure it's reliable and consistent. And then I think the other thing is about linking this. I think sometimes what happens is someone's got a delirium, you're doing things like making sure they're eating and drinking and opening their bowels, but it's not all joined up. So I sometimes worry that people are very carefully filling out food charts or stool charts, and they're doing it because they have to. But actually, it's really important. So if we get somebody eating and drinking well and opening their bowels, they're less likely to get delirium, and they're likely to recover from a delirium more quickly. So it's about engaging that whole MDT in what's going on with the patient and how what seems like simple nursing interventions are actually really important for patients' care.
It sounds like a lot of work for nurses.
Well, hopefully not, because like I said, some of the stuff is stuff that we should already be doing. It's just a way of joining it up. And hopefully I've also shown you that the 4AT in itself is not a very time-consuming tool to use. And I think there should be a lot of benefit from this, and I hope people will see the benefits when they do that.
What if someone can't talk? For example, I don't know, they're too drowsy.
Yeah, so that's a good one. It's one of the things that people struggle with. Can't do a 4AT. I would say that you still need to do one actually if somebody's drowsy. If one of the patients that I know is normally not drowsy is drowsy on my ward round and is unable to answer any questions, I'll tell you right now their 4AT is 12, and it will take me almost 0 seconds to do it, because you can still score whether there's been an acute change or not. The level of alertness will clearly be abnormal. They may not be able to answer any questions on the AMT, and they'll be untestable on months of the year backwards. So you can definitely do it on a drowsy patient, and that in itself is a bad sign that somebody's drowsy, and they're either at very high risk for delirium, or it's quite likely that they've got a delirium. And on the scale of delirium, those drowsy patients are the people with the worst outcomes. So you can definitely do it on drowsy patients.
Can you use it for patients with a stroke, or
Yep.
people who are deaf or who can't speak English?
Yeah, so people with a stroke, absolutely. So usefully, the 4AT has been validated in stroke patients. Again, it's because it's not all just about asking people questions, isn't it? There's some general observations about acute change and alertness as well. So if people aren't able to answer the questions, you'd score them as being unable to answer, and you'd observe them for acute change and tests of alertness. And clearly, the kind of patients where you're struggling with this are at risk. So it might be more challenging to diagnose delirium in those patients, and you might need to know the patient well to diagnose delirium. But in terms of just thinking about whether this patient's at very low risk or at risk of delirium, then that patient's at risk of delirium. So you definitely can do it in stroke patients. Patients who are deaf, obviously, it's challenging to do the 4AT. There's a number of ways around that, obviously, isn't there? Making sure that people have got their hearing aids in, making sure that you're communicating in the best effective manner. So I spend a lot of time quite close to my patients, and when they've got hearing problems, using signboards and allowing people to write the answer when they're and see the questions and write the answer when they're unable to talk. So there are still ways to communicate with people who are deaf, but appreciate it's a bit more time consuming. And I think you mentioned people who can't speak English. Well, clearly there's a challenge there as well. You need to get an interpreter. I think we've agreed that if you've got specific challenges like an interpreter or English not being their first language, that they might be excluded from the metrics because we're asking people are tested when they come in. But we should still be finding ways to test these patients, shouldn't we? In fact, they're at risk of delirium because of the difficulties they have in communicating with people around them.
Okay, thank you. I don't know whether you realise, but you're still sharing your screen.
No, let me go.
So we've lost some of you.
Let me go to that.
What about patients with dementia? Because sometimes they score positive, don't they, on the 4AT anyway?
Yeah, so there's a couple of things to say about that. So patients with dementia in NICE guidance, for example, are screened at risk of having delirium. So they should be treated as having being at risk of delirium. So if they score positively on the 4AT, that's no big deal. Like as we mentioned before, the most important thing is to identify people at risk and put in place measures to prevent or manage delirium. The key thing there is going to be knowing the patient in terms of making accurate diagnosis, isn't it? So knowing that the patient's changed and that this is not within the normal parameters of their dementia behavior will be how to diagnose delirium in those patients. But bear in mind, it's not a nurse's job to diagnose delirium. All it is to identify people at higher risk of delirium. So we still score people with dementia. We still do the 4AT on people with dementia. In fact, a very important group to do a 4AT on.
Are there any patients that we would exclude from needing a 4AT?
Yeah, so I think we mentioned the difficulties people may have. So I don't want people to give up on people who've got who are unable to speak English or may have problems with hearing. But I think we said for the metrics they'd be excluded from the 4AT. People in critical care environments as well don't need to have a 4AT. So it's the confusion assessment method for ICU that's best validated for that group of patients. And clearly, if somebody's coming to hospital and is actively dying, then we don't want to be doing repeated 4ATs on them. Having said that, delirium's an issue in palliative care as well. So for people who are in their last few days or weeks of life where delirium's an issue, then the 4AT might be relevant. But yeah, not if you're in your kind of last hours, day of life.
Okay, so I guess you're saying that these patients are high risk and would benefit from a delirium care plan, and you've shown us, I think, already what the care plan looks like. Do you think there will... Sorry,
yeah, I guess it's just worth mentioning about the care plan because people are new to it. So I think we showed you the document earlier, didn't we? But I think it's worth just mentioning that in terms of the narrative bit that people write at the back of it, that they should engage with the information that's on the front of it. So I think people are used to writing on confusion care plans, patient settled, patient confused, which, as we've discussed before, isn't very useful behavior. Very useful documentation. So actually, maybe writing something like this patient's at risk of delirium because they've got a 4AT of 3. They don't seem to be in any pain. They're opening their bowels. I've done a bladder scan that shows this. They need support with their meals. That sort of thing might be the more valuable things to write, providing a delirium leaflet. So yeah, look at those delirium leaflets. The delirium care plans. They've got loads of useful information built into them. We've not designed them to be burdensome, but to be helpful. But we do need people to engage with that process a little bit.
Do you think there will be any benefits for nursing teams?
In terms of preventing and managing delirium?
Well, yeah, absolutely, yeah.
Yeah, hopefully. So like we said, around 30 to 40% of patients of delirium cases are preventable. So if we prevent delirium, we should prevent falls. We know that from RCTs that falls go down if you do this reliably. You'll prevent distress to the patient who's not getting a delirium. You'll prevent deconditioning. You'll prevent a long length of stay. Should prevent admission to nursing homes and prevent death, and actually have less kind of work to do as a result of all these harms that are coming about coming from it. And then the other thing that's quite useful is that when you do have a patient with delirium, I think sometimes it's a bit difficult because it's hard to sometimes communicate with relatives who say that the patient's more confused than normal and it's not obviously apparent to us. Whereas now with this little bit more understanding, you can say, oh yes, well, this is how we assess it. We're going to do a 4AT, and how we're going to manage it is by looking at bowels, bladder, nutrition, hydration, medications, environment, all the rest of it. So I think it should be more rewarding in terms of reducing harm on the ward, and also in terms of engaging with the patient and their caregivers as well.
So you're talking about using the 4AT a bit like the news, aren't you?
Yeah, we have discussed that, haven't we? So I think the other benefit is the way we communicate with other healthcare professionals. On my ward J14, what we have done is when we discuss each patient on our daily MDT, we present them with their clinical frailty score and their 4AT. And that gives me a very good, quick idea of what somebody's like right now. So, and these are people, the other half of the ward that I've not met. So when the junior doctors are presenting, somebody's got a 4AT of 0, I've got an idea that somebody's alert and not more confused than normal and answering all the questions in the 4AT correctly. If they see their 4AT is 12, I've immediately got an idea that somebody's more confused than they normally are, drowsy, unable to speak, is quite ill. And when somebody says they've got a 4AT of 3, again, I've got an idea of somebody who's not very drowsy and doesn't seem to be more confused than they normally are, but are getting lots of things wrong on the 4AT. They might not know where they are. They might not know what's going on around them. They're at high risk of delirium. So in the same way that when you and I discuss a news of 5 or a news of 10, there's lots of heterogeneity within a news of 5, but you've got a rough idea that someone's kind of more ill than somebody in the news of 0. The same way when people tell me 4AT scores, I've got a rough idea of their cognitive state and their degree of risk.
It would be useful, wouldn't it, to be able to see the 4AT score on the PPM ward view?
Yeah, hopefully we'll be able to do that. We've requested that feature. It should be possible. I think that will be beneficial to teams to be able to kind of look through their ward and see who's got a 4AT of more than 0 and at risk for delirium, see who's got a 4AT of more than 4 and may have delirium. Yeah, definitely. So what we want to get to is this point where all older people in hospital are assessed for their cognition when they come in, and we're using that 4AT score as a way of understanding their degree of cognition and risk to bad outcomes.
One last question, how often would we need to do the 4AT?
So the 4AT should be done on admission. and it should be done when there's a new change. So if somebody's more confused than they normally are, so if you come onto a nursing shift and you can see that the person in bed 2 is clearly more confused than they were yesterday, you should repeat a 4AT. I also do them periodically, so I do them roughly once a week on my longest day patients, just to see how people are. I think it's the quickest way of understanding someone's cognition without having a kind of half an hour conversation with them. But for the purpose of metrics, we're only asking that it's done once on admission. So all you're going to be measured on for now, as people are getting used to this new concept, is a 4AT on admission. But good practice is on admission and when a condition changes.
So what are the next steps for this project then?
So you and I have got grand plans, haven't we? So we're just at the beginning, and what we want to see is 4AT done on everyone over 65 across the trust. And this might include areas that are not used to this. If their 4AT is more than 0, we want to see the delirium care plan being used to prevent delirium or manage it when it's there. We are obviously using this podcast to provide a bit of information around delirium, but we have also been doing education sessions specific for departments. We've provided a bit of promo. You can see the screensaver behind me. Some people may have seen that on the laptops or on the patient-facing computers. We've got a promo campaign around it. We want to get some data, which we should be able to do soon, in terms of seeing what wards are doing the 4AT, and we're going to find out from those high-performing wards what the secrets to their success is. Billy will be watching out for people that aren't doing the 4AT so well as well, and going in there to try and help them. And the plan is to get to every CSU. You and me in person are on teams over the next kind of year or two, and at some point we'll have a patient-facing campaign as well, because I think it is really important that we empower patients and relatives to say, I'm worried about my dad. That's not my dad. I'm worried they've got delirium, and that clinical staff can then respond to that. So big plans to try and make LTHT a place where hopefully people get as little delirium as possible in the first place, and if they do get delirium, they get really high quality care.
And sort of where can people find out more following this podcast?
So we've got our delirium intranet page, which has got some useful resources. It's got a much shorter video than this on just the 4AT and how to perform one, which could be shared with frontline staff. We've got our delirium guidance on there as well. Like I say, we're going to the departmental meetings to talk about delirium. And then the other thing to look out for is the frailty education day. So we've got one on the 28th of June for nurses, which will cover management of delirium, but also management of frailty, confidence, falls, all the rest of it. And we'll be doing more sessions on frailty education over the next year. So hopefully through a variety of means we'll get the message out there.
Thank you.
That's everything, I think. Thank you very much, Alison.